Version of failed uni to total knee arthritis, challenges and outcome. Dr. Neil Bradbury, thank you very much.
Good morning, everyone. So at these meetings, often what happens is all the speakers get up and they tell you the same thing and they all agree with one another. And it's kind of okay, but it's not much fun. So I thought what we'd do is we'd have a bit of a fight because you'll enjoy that and it'll be good fun. So I will tell you a little bit about my journey in the uni knee world before we start this talk. So I have been doing uni knees for 23 years. I was trained by the Oxford group. I started using the Oxford uni knee. And I did it for all of the reasons that we've heard about. It's a kinematic knee. You keep all the ligaments. Patients feel that the knee is like a normal knee. And all of those things are true. And then I started getting a few problems, and I kept doing it because I thought, well, I just need to train better and get better. And they introduced new instruments, which helped. But the truth is, this is not an easy operation. And Abton has just told us how we can do these knees well. That was a big list of things you need to do. So it is not easy. And I did 50 to 70 unis a year. So I was doing plenty of them. And he is absolutely right. There is a lower threshold for revision in unis. But in the United Kingdom, we have a thing called a joint registry, which tells us where and what has happened to our joints. And I know what my data is over the last, well, ever since the joint registry started. And of all of the knee replacements that have been revised in my practice, almost all of them are unis. And many of them have been revised by other surgeons. And you never know whether another surgeon has revised your knee, your uni knee, because it was easy to revise, because they were paid to revise it, or because it had a real problem. So the truth is, although this is not, in my view, an operation that we should decide is difficult and therefore we shouldn't do it, we should do it. Be clear, it's not that straightforward. So I'm going to tell you what to do, and I'm going to show you some of the things that happen when they go wrong. So we've talked about this, you've seen it, and this is really true. When you do uni knees, the patients have a full range of motion. They are happy with their knees, largely. They have better proms. They have reduced mortality and morbidity. They are very, very good. But we cannot get away from this, okay? And no matter what people say, the truth is, unis do not last as long. They just don't, currently. And I'm going to show you why they don't. Because part of it's about revision threshold, but that's not the whole story. So infection. Every knee can get infected, be it a uni or a total. And there's nothing special about the management of infection. I'm not going to talk about it because it's a complex subject. I always do two-stage revisions. And in the United Kingdom now, all infections should be and are recommended to be managed by specialist units. So the good news is I do my uni knee, it gets infected, I send it to Abtin. He has the headache. He's got to do the IV antibiotics. He's got to see the patients for several weeks. I don't have to do that. Aseptic loosening. So all knees get this. Does this happen more frequently in unis? Well, that's a very interesting question. And I'll just show you a slide in a moment about that. Malalignment. Okay, so here we go. We all think we're pretty good surgeons. The difficulty is knowing whether that's true or not. But I know, because I've had the data from the National Joint Registry, that my survivorship, my personal survivorship, is amongst the best in the country. So I'm not necessarily going to be the best, but I'm good enough to know that I'm good enough as a surgeon. But I tell you now, I've got some that look like this. And it is not easy, this operation. And in my view, the Oxford knee, in particular, has a set of instruments which are not that easy to use, even the new ones. And the new ones are better, but this happens. Overstuffing. I've overstuffed some of them. You put a poly in that's too thick. And the problem is, if a patient comes back in with pain and an X-ray like this, the temptation is to take out that poly and put a slightly smaller one in. That will not work because the MCL has already been stretched, so that needs a proper full revision. Subsidence. Abtin talked about the fact of a non-progressive radiolucent line. And this is where we're going to start having a fight, and you'll enjoy it. So the Oxford group are the group in the world who do more Oxford unis than anybody else and have published more about it than anyone else. And they, for a long time, talked about non-progressive radiolucent lines being not a problem. You can just forget about them, watch them, but they'll be okay. And that was in their cemented unis. Then they invented a thing called an uncemented uni to get around the fact that they had these non-progressive radiolucent lines, which didn't matter in the first place. Fishy. And it's true that the uncemented Oxford uni, you don't have that problem so much. So I started using it a lot, and I thought, my problems are over. It's much better. Uh-oh. But the risk of fracturing, and this isn't an Oxford, this is a different procedure, the risk of fracturing when you use an uncemented is higher. And you have to fix them. And poly spin out. This is where the plastic in a mobile bearing spits out. So how do we deal with a poly spin out? Well, the difficulty with poly spin out is this. Very few patients who spit their poly out think to themselves, oh, I've spit my poly out. I better sit in bed or at home and not walk on this and go to hospital. And if they did that, we could try to put the poly back in. The problem is they come in 3, 4, 5, 6 weeks later, having walked on the metal components, and they've ruined their metal components and they've got a black knee. So you've got to take it all out. And the other problem with poly spin out is that, first of all, you have got to work out, why has the poly come out? Did you put one in that was too small? Because if you just put the poly back in that's come out, it's likely to come out again. So poly spin out seems like it's an easy thing to fix, but it really often isn't. So let's talk about how we revise these things and what we do. So if you have a fracture down here, it is possible to do this with a buttress plate. And I've had some success doing those. I've had about 4 or 5 fractures in my practice. But it's by no means easy, and they don't all unite. And the reason they don't all unite is because the synovial fluid can leak down into the fracture, and you get a non-union. And the other thing you should do is, if you are going to fix a fracture, then don't do this, because this is not, in my view, satisfactory fixation, and AO principles would suggest you're much better off with a buttress plate on here. And the reason you can tell, can anyone tell me why this X-ray indicates the surgeon should probably practice a bit more? I'm going to be a bit more controversial again today. Well, the answer is skin clips. Okay, never use skin clips. Ugly. Patients don't like them. That's what surgeons do who can't be bothered to do some stitchery. How many people in the audience are starting to hate me now, I wonder? Okay, so how do we revise unis? Well, if you've got a big fracture, you will never fix that with a buttress plate. So you have to do something like this. And this is where we start to realize that the revision of a uni to a total is not always a simple case. It's often a very difficult case. And it's very important, if you are planning to revise a uni to a total, to make sure in theatre you don't just have total knee replacement, you have total knee replacement plus a full revision system, stems, wedges, and in some cases cones, because they can be very challenging. The big question I'm always faced with is this. So if you have a uni that has failed and is loose, do you put another uni in, or do you put a total knee in? And I'm going to show you some evidence later. The answer to that question is really simple. Always put a total knee in. Don't try and revise a uni to a uni. It is highly unlikely to be successful. The next big question is this. Do you do a primary total knee replacement? Or do you put a stem and a wedge in? And of course, that's largely dependent on how much bone has been removed in the first instance. I always try to do this. But the problem is, you then got to ask yourself, how deep does the cut have to be, and how big a poly do I put in? So if you've had a uni that you can revise and you put a slightly bigger poly in, that may well work well, but the difficulty you've got is you've then cut away quite a lot of the lateral side and you're right down to the fibular head. Or should you do this? Should you put a relatively small step wedge in and a stem, or a stem to here? And I can't tell you the answer because there is no evidence in the literature, and I talk to many people about this and nobody knows in terms of evidence. I tell you what I do. I try my best to put a primary total knee replacement in, and I will go up from a 9 to maybe a 13 poly, no higher. After that, I then put stems and wedges in. But often this is what you end up with, a big step wedge. How to get it wrong? Well, you do something like this. And in my view, what they've done here is they've just taken too much off, and also this is really not the sort of operation that should have been done on the basis that they could have got away with much less of a resection. So we'll just look at the evidence finally, and as always in these circumstances, the evidence is a bit patchy, and it's put together in these meta-analysis, which seems to give us a bit more confidence, but the problem is they really probably don't. So the predominant failure mechanism was polywear in this paper. It's a small paper. If we start looking at meta-analyses of the Oxford, big numbers. So the truth is, revision rates are reasonably quite high, and bearing dislocation was found to be the single most important factor. So we heard earlier that using a fixed bearing prosthesis might be the way forward, and I have moved away from using mobile bearings to fixed bearings. And the reason principally that I've done that is because poly has improved in quality, and I'm kind of hoping that the polyethylene we now use is going to be good enough, and I don't need the mobile bearing advantages. And this study from the Swedish Arthroplasty Register shows component loosening of 45%, joint degeneration of 25%. And these are very difficult data to get around. And I hear what people say about the fact that the revision rates are sometimes due to surgical thresholds. But I don't think that's the whole story. Thank you.